Patrice Wendling at the American Society of Hematology meeting, speaking with Dr. Ralph Meyer, who presented some results today that call into question surrogates used as endpoints in the study of Hodgkin's lymphoma. Doctor, how is this going to change practice?
Well, I think it will make both patients and healthcare providers and physicians more cognizant of the fact that for these patients who often are young, the median age in our trial was around 35 years, that it's their long-term outcome at 10, 15, 20 years that's particularly important, and that controlling the Hodgkin's lymphoma is a stepping stone to a long-term healthy life, but that the nature of the treatment and the late effects from it are also very important. I think that the interpretation of our trial will swing the pendulum towards use of chemotherapy alone and limiting radiation for special circumstances in patients who have special features, either in terms of not tolerating chemotherapy or in special features of their Hodgkin's lymphoma that puts them at risk of it progressing.
Given that the radiation dose used in your study is no longer current practice, how is this going to affect the interpretation of the results?
Well, that's going to be the major issue, and there will undoubtedly be lots of debate. The radiation used in our trial is no longer used. It was excessive, and it will have contributed to the gap between the chemotherapy arm and the radiation arm we saw. However, even with modern practices, we anticipate that there still are going to be issues with second cancers and cardiovascular disease. The trials testing more limited fields of radiation are less mature, but are already showing that deaths from other causes, including second cancers and cardiac events, continue to occur. And while they'll be less than what was seen with extended field irradiation, we anticipate they will still exist, and thus the results of our trial will remain important.
Currently, studies are going on looking at the use of PET scans in a treatment management course. How is that now going to also affect the results that you presented, given that that was not done during your study and is now being used to manage dosing?
Well, it's a very interesting question, and I can't give a definitive answer because there are randomized trials that are currently ongoing, both in the United Kingdom and in Europe. These trials are focusing on disease control and use endpoints like freedom from disease progression or progression-free survival, which we now show are not accurate proxies for long-term overall survival. I think where the potential of PET technology has the most opportunities to improve outcomes is in identifying patients with a positive PET scan after 2 cycles of treatment, and whether that identifies a special population where more treatment is needed. The nature of what that more treatment should be is going to be a subject of ongoing discussion and could well include maintaining a role for radiation treatment.
If it was your patient and they were positive on PET, would you continue with chemoradiation given what you know from your trial?
If I was convinced the PET scan was not a false positive, that is a patient I would use involved field irradiation with, yes.
Thank you, Doctor. Appreciate your time. Patrice Wendling at the American Society of Hematology.